part, a lot of it will be a sort of a teaching component of it. So candidate 2 now will be with us for a while, but you will get less cases and more teaching. Okay, candidate 2, case for you, how will you tackle it in your exam? So the examiner has opened on the software, and this is the image.
So I've got axial slices of the upper abdomen, a post-contrast scan, and I can see in the right lobe, just lateral to the falciform ligament, I can see there's a hyper-attenuating, somewhat circumscribed lesion. It's a solitary lesion on this single slice, and the rest of the imaged abdomen appears unremarkable. In a 32-year-old female with a solitary hyper-attenuating lesion in the lobe, I'd be thinking about things like a hemangioma. Adenoma would be fat density, so unlikely. The other thing could be an FNH, because it's not as hyper-attenuated, it's almost iso to hyper. So I'd put that in my differential as well. METs would be less likely, given that it's single and the way it appears and in this age. So I'd obviously like to assess it with an ultrasound or an MRI.
Right. So what is the phase of this single slice which I have given you?
I can see a contrast in the aorta, so it's an arterial phase.
Right. So basically, we are looking at arterially enhancing lesion, and it enhances on the arterial phase, and the differential diagnosis, we will revisit that differential diagnosis. So now I have given you non-enhanced, arterial, and venous. Can you describe it for me, and what is your differential now?
So on the non-enhanced, it's iso to hypoattenuating. On the arterial phase, again, it's hyper-attenuating, and on the venous phase, it becomes completely iso-attenuating to the liver.
So what is your differential now?
So I'm thinking whether this is a hemangioma, because it takes up contrast on the arterial phase and then gives it back on the venous. The other thing I was thinking, because sometimes METs fill in and then wash in and wash out quite quickly, but I'm not convinced this looks like a MET.
So what is your concept of the word washing out?
So basically, because the METs would have abnormal hepatocytes, so they won't retain, and some of them, and there will be necrotic cells as well, so they can't retain the contrast for longer. Whereas with an FNH, it's got normal hepatocytes, it has the ability to retain it longer because the cells are functioning. So.
Right, you are right. So the point is that this is a venous phase. And do you think that this is a washout?
I don't think it's a washout. I think it's become an equilibrium, so it's become iso-attenuating. With a washout, I would expect it to become low in density. So
take-home point is that the word washout means
that it will lose the contrast quickly and become lower than the liver attenuation.
Okay, so the take-home point is that look at the liver parenchyma, and if the lesion is lower in density or lower in intensity on MR, lower intensity on CT, then we say that it has washout. Yeah. Now, you have also considered hemangioma there. And why have you considered it?
The fact that it's slightly bright on the arterial, but I'd expect a hemangioma would be much brighter. Because on the MR, it tends to give us a light bulb sign, So I'm just following the same principle for CTs. I've done the fact that it becomes iso-dense to the liver on the venous makes me think that it's behaving like an FNH because it's become the same as the liver parenchyma.
So coming back to hemangiomas, do you expect hemangiomas to enhance completely on arterial phase?
No, they show nodular centripetal enhancement, and then they progressively fill in. So yeah, on the delayed, then they would have filled in nicely.
So is there a type of hemangioma which enhances completely on arterial phase?
A flash hemangioma takes up.
What is the definition of a flash hemangioma? Is there a size criteria for that?
Not aware of the size, but it's the one which immediately takes up contrast and then gives up the contrast rather than the classical nodular enhancement that we see, the centripetal nodular. It just uniformly takes it up and then gives it back.
Right. So what is your final differential now?
So my final differential would be an FNH.
And so other than FNH, what else can it be?
A hemangioma, a flash filling hemangioma.
Flash hemangioma, okay, well done. What else can it be?
So in a 30-year-old, not an adenoma because it's not behaving like fat.
And do you think that all adenomas behave, all adenomas should have fat?
It could be a lipid-poor adenoma.
So
in a female, so I'd put that in my differential. In a female who's on OCPs, they tend to have hepatic adenomas as well.
Okay, so can it be something malignant? Can it be metastasis?
It can, just looking at the age and the fact that it's a solitary and the liver's got a nice contour. There's no evidence of cirrhosis in the liver. The parenchyma appears unremarkable. So I'm thinking less along the lines of HCC or MET.
And are you confident? You're using the word less?
METs would be at the bottom of my differential. I'd obviously want to know more whether this patient's got any history of weight loss and want to know whether it's single or multiple lesions. On this slice, it looks like a single lesion. But obviously, with an MRI, I would be more confident.
Okay, well done. So what I have done today is I have given you a taste of what I use the word grilling. And this will happen. Usually when I am conducting these sessions, I just go through quickly, and I did it intentionally. And this is what is going to happen in the exam. FRCR exam, there is a black and white world and there is a gray world. The real world is many a time the gray world. But there are some things which are black and white. And when you are in the black and white world, you have to retain your confidence. And the concepts is what the examiners are asking for. Liver focal lesion is what I have realized is that it is quite a subject which is very difficult, which is considered very difficult by many of the students. So that's why we are going to spend a bit of time today on liver focal lesions. Now, three things. I'll go into a bit of a teaching mode, should I say. When you characterize liver lesions, there are three things which are important. The most important thing is enhancement pattern, and we will spend time on this. How is it behaving on arterial? How is it behaving on venous? Is there washout? Things like that. In some of the cases, gross pathological features like is there fat, is there blood inside, calcification, cystic, fibrotic component, this will change your diagnosis. Clinical history is critical in some of the cases. Cirrhosis, for example, if you see signs of cirrhosis or the examiner tells you that there is cirrhosis, HCC will be up there. Now, clinically, FNH, for example, is usually in young ladies, and it is an incidental finding. Hepatic adenomas, please consider when a patient is on oral contraceptives, anabolic steroids, glycogen storage disease, but the but is, do not think that adenomas will only occur in these conditions. It might be an incidental finding also. So we'll come back to this. Now, in your Chapman is this differential diagnosis, which is hypervascular lesions in the liver. This is 8.18. And if you see the subheadings, arterially enhancing lesions which persist on delayed phase. Now, a huge list there, and you get a bit intimidated, it's difficult. And then there is another one which is arterially enhancing, which are equilibrating on delayed phase, and which include things like FNH and adenoma. Here there were a few things like hemangiomas, mass-forming cholangiocarcinoma, and if I continue, hypervascular lesions, fibrolamellar HCC, then there are rare. When you read all of this, you get a bit, there is too much to learn. So let's go back to a simpler point to remember. And this is the key thing which you have to remember for your exam. It's quite easy actually. And please remember that in your real world also, these principles which I'm going to teach you, they will work in most of the cases. Always keep your minds open. You can be wrong, but generally speaking, these principles, they work very well. And another thing is, the frequency of a lesion. So, a rare lesion will, of course, be very rare. And in the exam, they are going to show you lesions which you see in your day-to-day practice. So, hypervascular lesions are very important for the exam. And this is what will come, focal lesions in the exam. So the benign list includes FNH, adenoma, and hemangioma. And the malignant list, HCC, hypervascular metastasis, and intrahepatic cholangiocarcinoma. Now, this is a viva question. What kind of metastasis can be hypervascular? The word hypervascular means that they enhance on arterial phase. So this is the list here: neuroendocrine, classical. Please remember things like carcinoid, etc. They are neuroendocrine tumors. Renal cell, melanoma, breast, sarcoma, colon. This you can add many other things also here. So this world, benign world, is very important for you to remember. You should have clear-cut concepts about it. FNH, by definition, focal nodular hyperplasia. Look at the word, focal nodular hyperplasia is not a neoplasia. Actually, what happens is that this is a hyperplastic response to a vascular malformation. And so there is an artery there, or which is supplying it, and it's a hyperplastic response, and it enhances on arterial phase. Clinically speaking, FNH, when you diagnose FNH, you are very happy. There is actually, we don't even advise follow-ups for these. We just sit on them. We are very happy. Now, with latest imaging, we are close to 100% in diagnosis of FNH, and nobody does biopsies. And this is what the examiner is going to. Even in last exam, some of my students, they got FNH, MRI, by the way, of FNH. Now, adenoma. Adenoma, as I told you, of course, it is more likely in patients who are on oral contraceptives, or males who are taking anabolic steroids, gym work, etc., bodybuilders, or patients with glycogen storage disease. But do not think that this is the only clinical scenario. Adenomas can occur incidentally, and there are three types, which are, I'm not going to teach you the types, etc. But please remember, that adenomas have got a malignant potential. 10% is, there are three types and two of them have got about 10 or more than 10%. Another type has got less than that. But the main point for you to remember is that adenoma is not like FNH. You don't sit on an adenoma. If you diagnose an adenoma, then you might, either surveil the patient. At times you have to do biopsies. Adenomas are very tricky and you have to be sure that you don't miss a developing HCC. Please also remember that adenomas bleed, and this is a classical exam case. They will show you adenomas which will bleed. The patient will be with spontaneous hematoma of the liver, and there will be a background adenoma. So, to differentiate between FNH and adenoma is critical, though both are benign, but clinically speaking, management-wise, they are different. And we have to learn, and this is what we are going to learn today. Now, hemangiomas, as candidate 2 correctly pointed out, there is a hemangioma which is known as flash hemangioma. Now, please remember, size is the criteria. Some people take 1.5 centimeter up to, some people say up to 2 centimeter. So basically they are small. They are small. And that is why they enhance completely on arterial phase. So this is known as flash hemangioma. Otherwise, classically, they will just show nodular peripheral enhancement with centripetal extension. So flash hemangioma is one of the differential. If you get in your exam a lesion which is 4 or 5 centimeter, don't even consider a hemangioma in your differential. Just consider these two things. Now, HCC, classical HCC will of course enhance. It will become arterialized, and that is what we are. The criteria. We'll revisit the criteria, but basically it will enhance. This is and similarly hypervascular metastasis will enhance. Cholangiocarcinoma is very tricky, and you have to learn. My mantra of you learn your pathology and make your radiology is what we talk about. Cholangiocarcinomas is what we call intrahepatic cholangiocarcinoma, also known as mass-forming cholangiocarcinoma. So don't confuse it. Cholangiocarcinomas can be intrahepatic and they can be extrahepatic. Portahepatis, for example, flat skin, or more distally also. But we are talking about intrahepatic cholangiocarcinoma. So this slide is the key on which we will build our, cases today. Now, we have already done this case, benign or malignant. Candidate 2, my question is very leading question. Just tell me your differential. I just want you to either say this or say this. What do you think?
I think it's benign.
Benign. Okay. So we will now learn why is it benign. So we have to develop that concept. Why is it benign? The differential. So I'm showing you an MR, but this is what we call the phases of contrast. There is an arterial phase, there is a portal venous phase, and there is an equilibrium phase. The arterial phase for liver is slightly late. It's not a classical CTA type of an arterial. Actually, if you want to do an arterial of the liver, you should be slightly delayed, 30-35 seconds. You should not do it, let's say 24-25 seconds, which is a classical arterial for aorta, etc. Because some of the tumors, they will not enhance, and they will enhance in this phase. This is arterial. And this is venous phase, which is about 70 seconds, 65 to 70 seconds. And then comes an equilibrium phase. Equilibrium phase is between 3 and 10 minutes. And where the contrast is in equilibrium with the parenchyma. And of course, we cannot do CT scans in equilibrium phase. We don't have the luxury. because of radiation, etc. But MR, nobody is stopping us. So we use this and we do multi-phases in MR because of that. Now, key point for you to remember is this one. Benign lesions, usually there is no washout negative. So if this is a lesion, if you see this is arterially enhancing, portal venous phase, it retains contrast, and in equilibrium phase still retains contrast. And the concept is that it should not become blacker than the parenchyma. The parenchyma will enhance, and the word washout is used when it becomes blacker than the parenchyma. Look at this case. This is a metastasis, and on arterial phase it enhanced, maybe a bit of washout. If you look carefully, there it becomes blacker or hypointense as compared to the parenchyma. And then on equilibrium phase, this becomes more obvious. So take home point is that malignant lesions show washout. This is the key thing to remember. Benign lesions, no washout. Malignant lesions, there is washout. And don't try to look at the lesion itself and try to decipher if it is losing contrast. No, just look at the parenchyma and see how it is behaving vis-a-vis, losing contrast. So this is a key principle of liver imaging, but beware of pitfalls. It's not perfect. This formula is not perfect, and there are pitfalls. So keep your minds open. Adenoma, at times they behave differently. Fibrolamellar HCC, cholangiocarcinoma, because it has got fibrous component. HCC capsule, again due to fibrosis. I will go back into details of these things to explain to you. But generally speaking, this is what we consider. If there is washout, means it is malignant, with a disclaimer of some pitfalls as I have mentioned here. If you do contrast ultrasound, I am not going to teach you contrast ultrasound. We do a lot of contrast ultrasound in our center. And in contrast ultrasound, this is what they teach you. This is a phase of liver where I am pointing out this, the liver enhances for about 5 minutes or so, 4 to 5 minutes. And they say that if something becomes blacker as compared to the enhancing parenchyma, then it is a bad sign. This is known as late phase black is bad sign, coined by Prof. Cosgrove from Imperial College, late Prof. Cosgrove. Many of our generation, we have grown up reading his books. So this also gives you the same idea. There should not be any washout. So this was the take-home point. Right. So candidate 2, what have we learned about? I'll ask you 2 questions. General principles. If there is hyper-enhancing, arterially hyper-enhancing lesion and it loses contrast on venous phase, benign or malignant?
Also malignant.
Watch out. Sorry, I'll repeat my question because I might have confused you. Arterially enhancing lesion, if it shows washout on venous phase or equilibrium phase, is it benign or malignant?
Malignant.
Excellent. So this was the take-home point. So if we go back to the case which we did here, this lesion is enhancing on arterial and it is not showing any washout. So we are in the benign world. But please remember, it is a small lesion, so we might like to keep flash hemangioma in differential. But having said that, the differentiation between adenoma and FNH is critical. So within benign, we should be able to differentiate. And how do we differentiate? We use MR for that. Right. So we have got two types of contrast agents in MR, and one of them is extracellular agent, and second one is known as hepatocyte specific agent. We will call this ECA, and this one HSA. ECA can be any trade names, whatever your, basically this is gadolinium, whatever your department is using. Here, HSA is hepatocyte specific agents, and these are the compounds which are there. Now, HSA, these are the compounds, and these are the abbreviated names, and the trade names are these ones. In UK, we use Primavist. In most of the EU, this is the name, and we have got no experience with multi-Hans here in our department, but we use this one, Primavist. Key point to remember is, it is a very expensive contrast agent, by the way. One vial will cost you 115 pounds versus for, the ECA, it is only 9 pounds. We use Dotaram in our department. And the key point to remember is the excretion of this. And this, how do we utilize it for imaging? So 50% of this is excreted through the liver, 50% through the kidney, which is usual, but 50% is excreted through the liver. And this is the key factor which we utilize. So what happens is that it is excreted by the hepatocytes. The hepatocytes will excrete them into the biliary system, and they go into the biliary system and even highlight the CBD and gallbladder, and they will go into the duodenum. So for that, we have to use a 20-minute delay phase. This multi-hands, which we don't use, if you want to use multi-hands, you have to do a 60-minute delay, and excretion through liver is only 5%. So I believe this is a more effective tool. Right, if you can concentrate on this one, it's a very busy one, but this is how we do an MR liver. This is our departmental protocol. So what we do is that we do usual, a T2 coronal, T2, we do a low TE and high T, what we call a highly T2 weighted sequence. So this is a T2 and this is highly T2 weighted sequence. At times it is helpful, please remember, as candidate 2 pointed out, the light bulb appearance, where a hemangioma will become brighter on a highly T2 weighted sequence. This sign was given a lot of leeway in old literature. Nowadays we don't, because all hemangiomas do not behave like this, and we have got so many other tools within this protocol that we don't give it as much weightage as we used to, the light bulb sign. Then we do a T1 weighted sequence. Now this is for your exam extremely important, and this will come in your exam not at all for liver imaging, for also adrenal imaging. Here we do in-phase and out-of-phase sequence, a post-phase or in-phase or out-of-phase, whatever you want to call it. And the key is that on an out-of-phase sequence, anything which is fatty will show signal dropout. And this is how you pick up fatty infiltration of liver, or within liver if there is a lesion which has got fatty component. Similarly, in the adrenal, which also comes in the exam, you know that adrenal, if there is fatty component in the adrenal, means it's an adenoma, it's a good sign. So, in your exam, you have to develop your eyes to pick it up that this is an opposed phase. I will show you later on how do you see that this is an opposed phase. Basically, on this opposed phase, there is an artifact, we call it etching artifact, also known as India ink artifact. This is a very small image, so you are not able to see it, but I'll show you again, where you will see a black line around the viscera. For example, around this spleen, there is a black line. Around this liver, there is a black line. This is the interface between this fat and the viscera. This is known as India ink artifact or etching artifact. So you have to develop your eyes on this, and the examiner is going to just open it for you, and he or she is going to expect you to pick up that this is an opposed phase. Then we do a diffusion weighted. Now the diffusion weighted of in body imaging, particularly liver, is different from a diffusion weighting for let's say the brain. And basically what we do is we give 4 sequences of increasing B value. Initially B0, then B300, B600, B1200. Now it all depends on your department. This is not etched in stone. This is what we are using. Even in our department, we were using slightly different B values. But basic point is that any lesion which shows restricted diffusion will be bright on high B value, and it will be low on ADC map. Now ADC map itself, unlike the ADC map of the brain, is very tricky, and there is a bit of physics and a lot of noise is there and things like that. So don't think that in every case you will see a ADC which is black to your eyes as just like the brain. So at times you don't even see the ADC, you just pick up what is bright on high B value and just call it that it is restricted diffusion. Now after the DWI, then we do a fat saturated T1 weighted sequence. And then we use an auto injector and do multiple phases. Arterial phase, venous phase. Venous phase is, as I told you, 70-second delay. Then 3 minute, 5 minute, 10 minute. So this is all equilibrium. And because we are using MR, we have got the luxury to do this. So all of this it all depends on how expert your radiographers are. It takes us about 35 to 40 minutes to finish this. But initially when you start, they might be taking more time for that. Now, and the key is that when you start doing this post-contrast sequences, some of these sequences are done as we are waiting for the next phase, etc. So, but I don't want to go into those details. Now, this protocol versus hepatocyte-specific contrast agent HSA, what is the difference? Only difference is we add a 20-minute phase. So it is simple as that. Everything plus 20 minutes. So in these 10 minutes, the patient is on the table, and of course we can design to do some of these sequences in between. Otherwise, the patient does not leave the table, and we do our 20 minutes. So this is the protocol. Now, a few things which I want to tell you, but I'll just go quickly. The slides, you can maybe take screenshots or pictures, whatever is there, and read the references which I have told you. But basically, diffusion weighted sequence is considered very sensitive sequence to pick up metastasis, and there is a lot of literature on this, and some people even think that you just add diffusion weighted and it will increase your sensitivity greatly, even for not just for metastasis, for lymphadenopathy, etc. It will show very well on a diffusion weighted sequence. There are some pitfalls. The pitfalls are that cystic or necrotic metastasis might be false negative, and then hemangiomas. Now, this is a point to remember. Hemangiomas are false positive. So do not think that anything which is restricted diffusion is malignant. And hemangioma is a classical benign tumor which will show restricted diffusion. Similarly, abscesses, just like your knowledge of brain imaging, will show restricted diffusion. As I told you before also, that it is difficult to reproduce the ADC. So at times you small lesion, you won't be able to pick up on ADC. This is a classical example of a metastasis in which the p values are slightly different, 50, 300, and 600. And basically what we do is, when we pick up a lesion on B0, we see it on then P50, then 300, and then 600. If it is still bright on 600, then you call it that this is restricted diffusion and this is metastasis. When we were doing MR of the rectum, I told you that some of the studies and some of the trials are going on this, that if there is extramural venous invasion, you remember I taught you how to pick that up on MR rectum. If you see it, some of the studies, they are doing some trials on this, that you should do diffusion weighted MR because there might be metastasis sitting in the liver, which you will miss them on CT scan. Right, candidate 2, sorry you were with me for a while, but now this is a case for you. In this case, what happened was that this is 67-year-old male, previous surgery for rectal carcinoma. Because of weight loss, previous history, they did a CT scan. And there is, on this CT scan, what do you think about this area?
So this area stays low attenuation on all the slices, and looks like a geographical kind of area. So I've got portal venous phase, and it's low on the portal venous phase, but obviously I don't have the corresponding arterial to check. So the liver has a normal contour, so unlike, doesn't look like a cirrhotic liver, unlikely to be an HCC.
So that's a very good word. You use the word geographical, right? And if you see this vessel, does it go through it?
Yeah.
And is there any mass effect on this vessel?
No. It looks like it's a focal area, geographic area, what we call the, I don't know whether it's focal fat sparing or...
focal fatty infiltration, right. But the but is, there's a vessel going here and it is not being displaced. So here we are quite confident But here, you see this thing?
Yeah.
There's a bit of bulge on. Are we happy that this is still focal fatty infiltration?
No, I think it's playing the falciform ligament and also displacing.
What will you like to do then?
I'd like to assess it with an MRI.
Okay, here you are. You asked for it.
Okay, so I've got.
First of all, tell me the sequences. What sequence is this I am pointing out?
So this is a T2.
Okay, I'll come back to these two. What is this?
This is a no, it's not T1, the fat is dark. Is it a T1 fat sat?
Excellent, T1 fat sat. This is an arterial, this is a venous, and this is slightly delayed, right?
Yeah.
What is this and what is this?
So the first one is an in phase, and the next one with the India ink appearance is an out of phase.
Okay, good. What is your conclusion? What is your finding? Now we have to crack on, so we'll just go quickly.
So the lesion which I saw on the CT, the most striking imaging finding here is that it loses signal on the out of phase imaging, which confirms my diagnosis that this is a fatty area.
Excellent, well done. So you can now mute yourself, and candidate 3 should be ready after I describe this case. So this is what we call focal fatty infiltration. The learning point here is, first of all, you have to see this is that post phase or out of phase sequence. And look at the outline of the viscera and this black line surrounding it. So this is the India ink artifact. So if you see this area, this is bright here, and it becomes so black. The rest of the liver, by the way, is also fatty, but this particular region, the amount of fat or the magnitude of fat is more, and that is why it was causing this bulge also. But with this, you are absolutely confident. Please remember, on the post-contrast and fat-saturated T1, still the appearance is similar to what we got on the CT scan. So this tells you the importance of this sequence. Here, this really increases your confidence to 100%. But if I just give you this equilibrium phase, you will say, oh, this is an area which is dark. It was, by the way, dark here also, but you will not be as confident. So this is focal fatty infiltration. Right. So next we go to candidate. If candidate 1 is here, by the way, if candidate 1 is here, raise your hand, otherwise we'll go to candidate 3. Okay, candidate 3? 1 is here, okay. So I will go to 1 now, and then we'll come back to candidate 3.
Hello, can you hear me?
Yes.
Thank you, sorry, some technical issues.
No problem. So this is just the same thing which I have already told you, in phase and opposed phase. And please remember that this is also used, so this is used to pick up fatty change, and this is also used for iron deposition. Hemochromatosis is an exam case. And in hemochromatosis, I will teach you a few sequences which you should know. But one, you also utilize these sequences to pick up hemochromatosis. And for that, the imaging features are totally opposite. The opposed phase will become brighter as compared to in phase. This is, just remember this. Okay, now the hepatocyte specific phase, which is 20-minute delay phase, has got up to 96 to 100% specificity for FNH, and it can differentiate between FNH and adenoma. So look at this example where this is non-enhanced, this is an arterial. You can see a lesion here with a central scar. There is enhancement, and on hepatobiliary phase, there is persistent enhancement, particularly peripherally. The scar does not enhance. The concept is that in FNH, there are normal hepatocytes, And normal hepatocytes it is excreted by the normal hepatocytes and it will retain the contrast. The adenoma will not behave like this. Adenoma, take home point, will behave just like an FNH till 10 minutes time, but in the hepatobiliary phase, it will not behave similarly. And that is how you utilize this to differentiate between the two entities. Now, this is from literature. Candidate 1, I will take you through the case and you will tell me if this is an adenoma or FNH. On a T2-weighted sequence, intermediate signal may be a central scar. Please remember, central scars can be in FNH. At times they can also be in adenoma. There are so many things in which there can be central scars. Now this is a non-enhanced. Arterial phase, there is a bit of enhancement. Venous phase, there is no washout. Till now, we are quite confident that this is, according to our principle, because there is no washout, that this is a benign lesion. And then in the hepatobiliary, it shows washout. Look at the parenchyma. It retains contrast to a level and it completely washouts. So candidate 1, what is it? A black and white diagnosis.
So in the hepatobiliary phase, we can see that the periphery of the lesion has taken up considerably less contrast than the normal hepatic parenchyma. So it's not composed of normal hepatocytes, and this is a hepatic adenoma rather than FNH.
Excellent. So till here, you make up your mind benign versus malignant, and here you make up within benign what it was. So this is a classical example. Now, hepatobiliary phase is also used now to differentiate HCC, a small nodule. This is one of the ancillary criteria now to diagnose HCCs. It's simple. You remember what is the basis? The basis is that normal hepatocytes, if there are no normal hepatocytes, it will be low signal or show washout in the hepatobiliary phase. This finding can be, or this concept can be utilized to pick up small HCCs. This can also be used to pick up small metastases. Look at this, sensitivity in MRI is equal to FDG PET. So all of these tools, if you use them together in difficult cases also, literature tells you, I'm not going into that, Lyride, etc. But literature tells you below 2 centimeter MR is not, the sensitivity decreases. But I have got cases which we have seen in which up to 7 millimeter nodules we have diagnosed correctly. And time told us that we were right because of using of all of these tools together. But that's slightly beyond 2B world. So don't worry about it. You're in 2B, FRCR 2B, you just have to remember the major concepts. So this case has already been seen, and on our criteria, non-arterial enhancement, no washout, it is benign lesion. And then we concluded if it is benign, it can be an FNH, it can be an adenoma, and it might be a flash hemangioma because the lesion is small. So to differentiate between the two, candidate 1, what we like to see? 3 of them, should I say?
So to differentiate between those benign diagnoses, options we should compare with another modality, and ultrasound might be helpful, but a contrast-enhanced MRI would probably be the most specific.
Okay, so this is the diagnosis, FNH and adenoma, and this is the MR. So because of time factor, I'm going to take you through it. This is a post phase, this is in phase. What is your diagnosis? This liver, what do you think? Is this normal liver or fatty liver?
So there's not really a significant difference in the signal between the in and out phase. So probably there isn't significant fatty infiltration.
You see, the signal should be absolutely equal. This signal...
Okay, so it's a bit lower in the outer phase.
So this is fatty liver.
There is some generalized fatty infiltration.
Generalized fatty infiltration. Now, because you are seeing a generalized fatty infiltration, you are also going into the world of, can it be an adenoma, right? Now, please remember that hemangiomas are usually bright on T2-weighted sequence, and I have not shown you, but this one was not bright on T2. This is a pre-contrast fat saturated, arterially enhancing. This is arterial, venous, 3 minute, 5 minute, 10 minute, and hepatobiliary phase. This is 20 minute. What do you think it is?
So the enhancement behavior of the focal lesion that we've previously seen on CT is avid arterial contrast enhancement, which is retained throughout the delayed phase, and it remains enhancing on the hepatobiliary phase. So I think this is most likely to be an FNH.
Excellent. So if you see here, till here, according to our principle, it is definitely benign. And here we have clinched the diagnosis because it contains normal hepatocytes which retains contrast. And as I told you, this case has come in the exam last time. So this is a case where on a T2-weighted sequence, this patient had, actually, this is breast carcinoma staging. There on CT scan, there were some lesions, and then hepatobiliary phase was done. And on this T2-weighted sequence, you can see this high signal. And then on arterial, they show enhancement. Venous phase, this is it, still retains contrast. And on hepatobiliary phase, still retains contrast, particularly in the periphery. So please remember that peripheral, at times what happens is all of the lesion might not retain contrast, but the periphery will be. It is considered the same thing. And so conclusion is that this is also a candidate one. What is it? Is it metastasis or?
So multiple FNH.
Multiple FNH. So even with a known malignancy, you can be so confident in calling them FNH. Now over to you. You describe this. Let me tell you that there are two lesions. One is this one, another one is this one. This is arterial phase, and you describe it. Over to candidate one.
Okay, so we have selected axial sequences from contrast-enhanced MRI of the liver. There are two lesions, as pointed out, in the left and right lobes, which are not very conspicuous on the pre-contrast T1, and they show avid arterial contrast enhancement with they equilibrate to the liver parenchyma on the venous and delayed phases, and then I think we probably, is the bottom right a hepatobiliary?
20 minutes, yes.
And so as far as I can see, they remain equal in intensity to the liver parenchyma on the delayed phase. So, sorry?
Both of them? So lesion 1, lesion 2.
Oh no, so sorry, I got confused because lesion 2 is so near where I'd expect the IVC to be. So actually they behave differently. Lesion 1 is arterially enhancing and then equilibrates. Lesion 2 is arterially enhancing and then washes out. They both have benign characteristics, but likely would represent lesion 1 and FNH, and lesion 2 and adenoma.
Excellent. So this is a good example where, you can give a black and white, diagnosis. So this is what it was. This was arterial, did not show any washout in any phase and retained contrast on hepatobiliary. This one did not show any washout, but then it did show washout on the hepatobiliary.
Yeah.
Okay. Now, because of time factor, part of it I will tackle it and rest I will ask you leading questions. So on a T2 weighted sequence, this patient was 59-year-old. You can see loss of weight, back pain, deranged LFTs, multiple lesions on T2 weighted sequence. On a T1 fat saturated sequence, you can see this high signal here. And you can see this high signal without fat saturation also. This is fat saturation, this is without fat saturation. Tells you that this is not fat, otherwise it would have saturated. So what do you think it is?
So these lesions have got inherently high T1 signal, and they're multiple. In the context of an older patient with other suspicious features, I'm worried about disseminated malignancy with inherently high T1 signals such as metastatic melanoma.
Melanoma, okay. Did you pick up something here in the spine?
Yeah, and we told the patient has back pain and there's a vertebral lesion with similar characteristics.
Yes. So the point is that this was just to go through this differential, which is in your book, 8.223, T1 hyperintense liver lesions. And, fat, hemorrhage, cirrhotic nodules, melanoma, these ones you have to remember, particularly melanoma, and particularly anything which has got fat. So T1 hyperintense. On a DWI, look here, this is B1200. And what do you think? Benign or malignant?
So the lesions demonstrate high signal on the high p-value DWI images, which is consistent with restriction of diffusion. There's also many more lesions apparent on this more sensitive sequence, and I think this makes me more worried that this is a disseminated malignancy.
Excellent. So this was melanoma metastasis, and if you see here, this T1 is very interesting. On a T1 weighted sequence, you can see this high signal here. And usually high signal on a T1 weighted sequence is a good news in marrow, but this is an exception. Here, usually melanoma metastases will, they can be what we call a melanocytic melanoma metastasis also. But some of them, the melanin part is so much that it can, even in bone, it can show you. This is a very rare finding actually. Usually you will see low signal on T1. And on a stir sequence, there is a bit of chemical shift here. And so this was metastasis. And on the scout also, you can see high signal on T1. And within the liver, you can see all of correction. Within the spine, you can see this high signal. This is a fat saturated scout. So this is melanoma metastasis. This is your last case, candidate 1. This is not a metastasis, right? This was a cyst. So on this slice which I have given you, is there any other lesion? We are worried about metastasis.
So it's difficult to say on a single axial CT. I wonder if there's something very ill-defined and mildly hypoattenuating in the left lobe.
What will you do for this?
So I would probably do an MRI or an ultrasound.
For that, you are sitting in the exam. This is a viva question. Something which you can do here and then.
So something I can do right here to change how I feel about this is windowing the differently.
Excellent. So the point here is that there is a window, we call it, and this scenario has been asked by the examiners. Liver window, which increases our sensitivity. And in liver window, this is the liver window in our backs. It might be slightly different in yours. So now with this, what do you think, candidate 1?
So I'm convinced there is something real there. It's got quite poorly defined margins, and it does look quite concerning. But I'd still potentially use another.
So this is the MR. What do you think it is?
Okay, so this lesion remains very poorly defined. There's some hazy, mild increased T2 signal intensity, and it has arterial enhancement with washout relative to parenchyma. So I think it has definitively malignant features.
Yeah, so it shows classical washout. Okay, so I think this is a break time. We will 5 minute break and then we will start with candidate 3. So thank you very much, candidate 1. I'm going to mute myself for 5 minutes. Right. Candidate 3, are you with us?
Yeah.
Okay, candidate 3. Let me clear all drawings. So if you see here on ultrasound, there was a mass in this case. Mm-hmm. This mass on T2 weighted sequence and on this DWI sequence, how will you describe it? Over to you.
So it's a selected slices of MRI liver, T2 slightly heavy elevated T2, and then T1 non-contrast, and then diffusion weighted images, which is demonstrating slight hyper-intensity, intralesional slight hyper-intensity in the right lobe of liver where the lesion is, which is, I think, losing its intensity slightly on heavily elevated T2, while on DWI there's diffusion restriction. On T1 the signal is hypointense.
Okay, so with this bright DWI, high DWI, benign malignant?
Malignant.
Okay, so on arterial phase, the patient moved a lot, and this usually happens on arterial. Having said that, you can see a bit of enhancement, then venous, then this, then this, then this. Can you describe it?
So on venous phase, there is some peripheral nodular enhancement, which at 3 minutes, 5 minutes, and 10 minutes, there is gradual enhancement, centipetal enhancement pattern of the lesion. Which is peripheral nodular.
Okay, so what is your conclusion?
I'm thinking of now hemangioma, because hemangioma can be diffusion restricted, and with this contrast enhancement pattern, hemangioma comes into my top differential here.
Okay, but the point is that if you just see this periphery of the lesion, there is a central scar.
Yeah.
If you see the peripheral of the lesion, it has shown washout, correct or not?
Correct, yeah. Correct.
And why you are confused is, and this is the teaching point here, and this is what I am going to teach you now. Why you are confused is because the central part has now enhanced, right? Agree? This is what has confused you.
Yeah.
So this looked malignant, but because of this centripetal within inverted commas enhancement, you are now confused. And the point here is that this is a fibrolamellar HCC. Now what is happening? That the central part is fibrosis. So what happens is, there are two differential diagnoses which we have to cover here. One is liver lesions with a central scar, focal nodular hyperplasia, fibrolamellar HCC. There are many things which can have a scar. Even metastasis can have a central scar. And there is another differential which is what we have to cover here. Liver lesions with gradual delayed enhancement. Mass-forming cholangiocarcinoma, hemangioma, you can add, this scar also there. What happens is, first of all, mass-forming cholangiocarcinoma, what we call intrahepatic cholangiocarcinoma, has got various patterns. And the pattern which is for 2B is this one, mass-forming. It will be just like a mass. Now, if you know your pathology, you can make your radiology here once again. Basically, people do confuse it, hemangioma versus intrahepatic cholangiocarcinoma, or any tumor which has got a fibrous scar basically what happens in a intrahepatic cholangiocarcinoma or a mass-forming cholangiocarcinoma, the active component of the lesion is peripheral, and centrally there is a lot of fibrosis. This is histologically speaking. This is the behavior of it's a serous type of tumor. And similarly, there are some metastases which have got similar histology. So there will be a bit of fibrosis centrally. Now, if you look carefully, if I come out of my pointer option, I am just trying to change it into. Now, if you look carefully, there is a bit of enhancement in this lesion in the periphery. This is an arterial phase. Actually, enhancement. Now, just keep comparing it, and you will see that it is enhancing. Gradually, there is what we call centripetal extension. No, this is not that hemangioma type of enhancement. This is fibrosis. In hemangioma, one take-home point will be that the periphery of the lesion shows nodular enhancement. Number two, it will not be continuous enhancement. There will be some gaps there. Another point to remember is that in hemangioma, the signal intensity of the enhancement is equal to blood pool. We use the word blood pool. What does it mean? It means that it is equal to let's say the vessels in the the hepatic vessels or the portal vein, etc. That will be the signal. So otherwise, and you will confuse it. So scar or fibrosis will enhance with delay, and that was the learning point in this case. Look here, this is intrahepatic cholangiocarcinoma, which is quite peripheral. It is here, and there is a dip in the capsule of the liver. This is the dip. This is what we call retraction of the capsule. Now, if you see inside the lesion, this is arterial. There is peripheral enhancement, and then it shows enhancement on the delayed phase. And similar behavior can be shown with what we call serous metastasis, particularly breast metastasis. Please remember that there is an appearance in liver imaging, we call it pseudo-cirrhotic appearance. And I've seen cases of breast metastasis which are so serous that they will cause outline of the liver will be totally, nodular. So how do you differentiate this? I repeat, with a hemangioma. First of all, on a T2-weighted sequence, a hemangioma will be more brighter. Number two, the enhancement will be nodular. It will not be continuous on early arterial phase. Number three, the enhancement will be equal to the blood pool. What does it mean? So if you just concentrate here, this is the portal vein or the hepatic vein, and you see inside the lesion and look at the enhancement inside the lesion, it is not equal to that. It is less than that. And look here, it is not equal to this. So these are the discriminators between intrahepatic cholangiocarcinoma versus hemangioma. This one I'll skip it. Okay. One case which has come in the exam many a times, I've got a very good MR also for this, a similar case, which I might show you if I've got time in the end. The problem is that many of these cases are on DICOM sequences, and usually when I do teaching, I show it like that. On Zoom, it becomes a bit cumbersome to, screen sharing, etc. Everything takes time. So what I have decided is that once we go through all of these courses, then we will design a few courses in which we'll just go through them as long cases, etc. Mix and match of cases. But having said that, one thing you have to remember, this kind of a case has come in the exam many a times. They will show you, what we call tumor thrombus in the portal vein. And you will be, because you are thinking it's enhancing vessel, then you look carefully. Look at this case. This is an arterial phase. And on this arterial phase, you can see the portal vein. Why should you see the portal vein? Either there will be a shunt. There was no shunt in this case. Actually, this is a tumor thrombus. And tumor thrombus because it had gone into the portal vein, grown into it, and this case was a cirrhosis with HCC. Okay, candidate 3. So in this case, we picked up 2 incidental focal lesions, 62-year-old male. One was this, one was that, and then we did an MR. Over to you.
These are selected MR slices through the liver in different phases. So you've labeled them as well. So the lesion in question is the left.
Okay, so let me just guide you that actually on MR 4 lesions were visible, but I'm just showing you one lesion, which is this one. Just describe this lesion, please.
Okay, so the lesion is P2 hyperintense compared to the rest of the liver, and T1 hypointense, while on in and out of the phase, it loses its intensity. So there is some signal loss, intralesional patchy signal loss within the lesion.
So you think it's fatty, right? Okay, good.
Yeah.
A bit of restricted diffusion, right? Still bright on B1200. Bit of restricted diffusion. And then I show you contrast.
So on contrast, there is some enhancement within the lesion.
So what do you think? It is, benign, malignant. Where are we?
There is some. So I can't see any washout on this first thing which I noticed. So there is a gradual contrast enhancement rather than washout.
The word washout means, please remember that washout means, there are 2 different things which you have to look into this case. What is happening inside the lesion, but vis-a-vis parenchyma, what is happening? If you see parenchyma, arterial phase, parenchyma is enhancing. Within the lesion, there is just a bit of enhancement. Rest is not enhancing. It never becomes equal, but within the lesion, there is a bit of delayed enhancement. So there might be, let's say, some component which is enhancing. But with restricted diffusion, with this kind of finding, what do you think it can be? And the idea is, that it has got fat. So what can have fat?
SEC. S is my top differential here.
So it is totally fatty actually. So this is actually a long case, which of course I had not shown you other bits. This is on a CT scan, it becomes very impressive where it had fatty change just like this MR, and there was a liposarcoma sitting there, incidental. So this is a type of a long case. Of course, I did not show it to you as a long case, but I wanted you to keep an eye open for fat-containing lesions. And metastasis from liposarcoma in the liver have come in the exam. And this is the idea to show it to you. Liposarcoma metastasis. Okay. So this patient is post-trauma, and there is a laceration here. On limited CT scan, there was a lot of upper abdomen, this fluid, loculated fluid. And what should you be worried about?
So the bleeding, the density of the bleeding is not that. After 2 days, obviously in my day-to-day practice, I would check the Hounsfield unit, but there's a lot of fluid.
This was not hemorrhage. This was not at all hemorrhage. This was like water.
Okay, so there's a lot of loculated effusion. I'm worried about loculated ascites for whatever reason, whether the patient has got some pre-existing disease causing this.
Pre-existing disease?
Sorry?
There was no pre-existing disease. There is a laceration hint. What comes to your mind? What else can happen?
One is bleeding, one is bilioma, or biliary leakage.
So biliary leakage, very good. So what will you do? How will you confirm it? Why was
So with biliary leakage, I would do MR.
Before that, how will MR help you, by the way?
MR will not really help, to be honest. I would do ultrasound scan.
For that, how will ultrasound scan help?
Or fluoroscopy will help as well.
How will fluoroscopy help you? What will you do in fluoroscopy?
I mean, I was thinking of PTC cholangiogram, but
the PTC, can you do a PTC if intrahepatic ducts are not dilated?
No.
Yeah or no?
No.
Yes, no.
No.
You can never do a PTC. Please remember, if intrahepatic ducts are dilated, only then you can. And in trauma with lacerations, that you should not do it in any case. But you won't be able to do it. The answer is, and this is a classical scenario, it has come in the exam many a time, this kind of a case. You have to keep your minds open about this, biliary leakage, where you just ask the clinicians to put in just tap it, send it to the lab, bile salts and bile pigments, and you got your diagnosis. Once you get the diagnosis, then you have to image it. And for imaging, you have to do, what is this? What procedure has been done? Candidate 3?
Yeah, ERCP has been done.
And leakage or no leakage?
There is leakage.
Right. So basically what I have seen it many a times that many of the candidates have used, I will do an MRCP. Now please remember, you need a dynamic cholangiogram to diagnose it. Two kind of cases will come in the exam. One is post-trauma, like the case which I showed you. Another one will be post-surgery. Dynamic cholangiogram is, you can do an ERCP, just like this case or this case. You can also do nuclear scanning, HIDA scanning or DCIDA scanning. But you can also use a new technique. And this is, I think, a distinction type of an answer if you want, where you can do a T1 weighted MRCP with HSA, hepatobiliary specific contrast. What we do is that, if you see here, go back to the basics, that 50% of it is excreted by the biliary system. So actually it will be excreted through the biliary system. And so this is the gallbladder. And the technique which we use, I have got an experience of about, I think, 12 or 13 cases which we have done. And this is very very unusual to do it. We will only do it if we cannot do the other bits. So this is not the answer for your FRCR, but it might be a distinction question or a scenario where you can impress the examiner by your knowledge. Basically, nuclear scan is up there, but if nuclear scan is not there, ERCP you can do, which is a bit invasive, and you can also do this technique if both are not available, or for some reason you cannot do an ERCP. Please remember, MRCP or PTC is the wrong answer. MRCP is a T2 weighted MRCP. There will be fluid inside the biliary system, there will be fluid outside. How have you confirmed that there is a leakage? You cannot confirm. It has to be a dynamic cholangiogram. And similarly, PTC, of course, PTC you cannot do without dilated ducts. So for this, what we do is that we do about 60-minute delay. Instead of 20-minute delay, we give it more time and it will excrete. I'll show you an example shortly. We've done about 12 or 13 cases, and only in 3 or 4 we were able to answer the question. In others, we were not. but to delay it further, you might get more better answers. This is your last case, candidate 3.
These are selected CT slices through the liver in different contrast phases, from the right to the left, arterial to delayed, which is demonstrating on arterial phase there is hypoactinated lesion in the right lobe of the liver, which is demonstrating peripheral nodular. The other country is a nice one, but there's more nodularity to the rim of it, and there's a centripetal pattern of filling on the delayed image. There's no capsular retraction associated with it, and so my differential here, my thought process was that this is representing a benign hemangioma.
Okay, good. So if you see here on arterial phase, it does not show much enhancement. It can at times also. Then you picked up well. In this particular case, we did a few delayed phases, and this is what we used to do before the MR world. And you can see this nodular enhancement, which has occurred slightly in a slightly late phase. And then initially, you have to remember that there is nodularity, but it is not continuous, number one. Number two, look at this enhancement, and you will agree that this enhancement is equal to the blood pool. Look at this phase. Now the nodal, there is a bit of centripetal extension, and again this is equal to the blood pool. Look here, it is completely centripetally extended to the center, and it is equal to the blood pool. So this is a classical hemangioma. Okay, thank you very much. And candidate 4, are you with us? If candidate 4 is candidate 5, are you with us? Raise your hand, please.
Hello?
Okay, I can actually... 4, yes. Okay. So, this is a case in which ultrasound, this is an ultrasound exam, 62-year-old, this was the lesion. So, we did MR, and you just comment on these sequences and then I'll show you contrast. Over to you.
Okay, so I've got MR series, axial slices, the lesion is hypo-intense on T1, hyper-intense on T2, hyper-intense both on ADC and DWI, which would indicate kind of a T2 shine through rather than a genuine diffusion restriction. The lesion becomes more apparent on the coronal T2, that there is kind of more of a hazard.
Okay, so that's fine, and now we have gone to contrast.
So now we've got contrast from the left to right, from non-enhanced through to delayed. There is some peripheral enhancement starting in the venous, then some intralesional definite enhancement within the centre of the lesion at 3 minutes, 5 minutes, and to the point at 10 minutes where there's kind of the most maximal enhancement of the lesion. So in summary, this lesion is more kind of enhancing predominantly in the delayed aspect of the contrast series.
Conclusion?
My concern is that this represents a intrahepatic cholangiocarcinoma in this context.
And why isn't it a hemangioma?
Pardon?
Why isn't it a hemangioma?
It's not a classical centripetal fill-in, so it's not peripheral then going centrally. It's centrifugal.
Okay, so, right, okay. So the point is that this is a giant hemangioma, and giant hemangiomas are by definition more than 10 centimeter. And giant hemangiomas, you see, it's quite big, right?
Yeah.
And it is bright on DWI. Now, if you see the contrast enhancement, of course, maybe you are a bit handicapped because you are just getting one slice. There is actually a nodular enhancement. Here it is less, more so, then more, then more, and then more. A large portions of a giant hemangiomas might not enhance. Please remember that. And there might be scarring, and some people say that there might be some thrombus sitting there. So large portion might not remain unenhanced. Even here, the same formula of is it equal to the blood pool, you have to remember that. Look at the enhancement pattern, and you will agree even on this late phase, it is equal to the blood pool. Look here, and it is equal to the blood pool. Look here, and it is equal to the blood pool. So this is another giant hemangioma. Now, why I'm showing you a giant hemangioma, that it has come in the exam quite a few times, and many people confuse it for the simple reason that they have not seen it, and in their usual practice. This is another giant hemangioma where on a T2 weighted sequence versus a highly T2 weighted sequence, it is brighter here. Then look at this enhancement, which is peripheral, and then of course we have not delayed phase. We don't know if it is 10 minutes or whatever, but a large portion might not enhance. That doesn't change anything. So this is still a giant hemangioma. Okay, candidate 4. So this is a 36-year-old female, came to A&E with acute abdomen. Oh, sorry, I have written the diagnosis there. So maybe I'll just tackle it as a teaching case. Now, if you see here, this is a classical case, again, which has come in the exam, where a patient they will show you a CT scan like this, and you will say that there is an intraparenchymal hematoma, and this is in keeping with trauma or whatever. And then will come this bombshell that there is no history of trauma. Or you will ask the examiner, and the examiner will say there is no history of trauma. So it was spontaneous. And this is what I wanted to show you for the exam. Spontaneous liver hematoma, particularly in young female like this. Please remember adenomas, and the patients will come to the A&E with bleeding. So this is, picture, and this is a similar case. I have already showed you this case in which I showed you the capability of hepatobiliary specific contrast to differentiate between an FNH and an adenoma. And if you remember, this case has 2 arterially enhancing lesions, and they did not show any washout, so we were happy that they are benign. Then on the hepatobiliary phase, one retained contrast, so this was an FNH. Another one lost contrast, and this was an adenoma. Just to make a point that here, this patient is a 29-year-old with glycogen storage disease, and this patient is she had 6 adenomas actually, and this is one of them which I am showing you on these slides. Okay, candidate 4. This patient, you are doing an ultrasound scan and you have picked up sort of ascites. What is happening here in the liver?
There's scalloping of the liver.
Excellent. So what comes to your mind? Will you highlight this in your report, or you will just sort of...
Concerned about kind of peritoneal carcinomatosis, also a process that's causing deposits on the liver. that is then causing extrinsic compression and scalloping.
So this is a CT scan of the similar anatomy, so what you saw on ultrasound, and I'm also showing you a T2 weighted sequence. So with this appearance, what comes to your mind? You are absolutely right, this is scalloping, but I just wanted to listen to a word there. Basically, how does it happen? Because you see, the argument is that there is nothing sitting there, nothing, no soft tissue or any mass sitting there.
Mm.
So, there's a word which, anything comes to your mind regarding appendix or ovary and...
Mucophyll, so it's...
yeah, close, you're there? Okay, so the word is not coming to...
There we go, pseudomyxoma.
Here you are, I knew it. Yeah, good. Well done. So this is pseudomyxoma peritoni. And pseudomyxoma peritoni, of course, the most common, and it can come as a long case, please remember. Basically, there is this mucoid material which fills up all of the peritoneal cavity. And the key thing in the exam will be scalloping on the outer edge of the liver. Radiologically speaking, this will just look like ascites, but that scalloping is what you have to pick up. The most common cause, by the way, is appendix, tumor. So look at the appendix very, very carefully, and it might be very small, and everything otherwise will be very large. Similarly, look for ovaries. In this case, this was an ovarian lesion. It can also come from colon, but appendix is most important for the exam. Appendix. Another case of pseudomyxoma peritoni, that scalloping is the main thing which I wanted to show you. Another case, but this one is slightly different because in this one you can see some soft tissue also there, but usually you will not. Pseudomyxoma peritoni. Okay, candidate 4. Now, T2, T1 pre-contrast, DWI, what do you think it is? With pain, abdomen and fever.
I think this is a hepatic abscess because I've got central low hypo-intensity on T1, hyper-intensity on T2, and then with an enhancing kind of capsular and borders and restricting borders.
Yeah, so this is a abscess which shows restricted diffusion, and on contrast it showed enhancement, some septations, etc. This is an interesting case, and actually this was a fish bone which had gone spontaneously into the liver, and this is reported in literature. This fish hypothesis is that the patient actually ate it, and it just penetrated, it went to the stomach and then penetrated through the stomach into the liver. And case reports are there where fish bones have even gone into vessels and they have gone to some other part of anatomy through, going into the vessels. So this is an interesting case. Last case for you, and then candidate 5 should be ready. So this patient came to the A&E, and what do you think?
There's increased density within the right upper quadrant and depression of, so the gas pattern within the right, the hepatic flexure is kind of pushed inferiorly.
So what will you do?
So suspicion that there's hepatomegaly. In the first instance, in a 24-year-old, I would do an ultrasound scan. Excellent,
very good, because if you had asked for a CT, I would have stopped you there. So that's a very good answer, and this is what they want to hear in the exam also. On ultrasound, can you characterize this? Characterize means have you got a black and white answer or no?
No, I don't have a black and white answer.
Okay, CT scan. Have you got a black and white answer?
That in combination with the CT, I'm worried whether this is kind of a high dated cyst and there were cysts that were more.
Excellent. How can you confirm it?
The patient should have a eosinophilia within their blood screen. I don't think you don't want to biopsy them or aspirate them because it can cause a kind of hypoeosinophilic and anaphylactic reaction.
Okay.
So
imaging-wise, would you do anything else? Or would you
do an MR?
So this is the MR.
So
I will, because of time factor, I'll ask you leading question, confirmed or not?
Yes, I think so, confirmed.
Okay, so these are internal membranes. Please remember, hydrated cyst. Thank you, candidate 4. And candidate 5, I'll ask you to raise your hand in a while. Hydrated cysts are important for the exam. Many scenarios in which even brain, chest, liver, peritoneal, all of them have come in the exam. There are many features of hydrated cysts, and sometimes they can give you, on some imaging, they can give you pseudo-solid type of an appearance like here, right? And this is internal membranes. You can see those subtle membranes here, but generally speaking, it looks like cystic, and then on MR, it is there. So the viva questions are that you can ask for serology for hydrated, and biopsy, of course. Classically, we were always told not to do a biopsy. There are some studies in the literature which tells us that people have done 70 odd biopsies and nothing happened, but somehow or the other, this concept still persists. Don't put a needle inside. So that is fine. So candidate 5, are you with us? Can you hear me, please?
Yeah.
Okay. Now, is the liver normal?
No, it's abnormal. The density of the liver is quite high when compared to the spleen, so it's hyper-attenuating. I could think of possible causes as amyotrophy or I don't know.
So liver density, right? So it is abnormal. Very good. So the point is that this is from your last Chapman. CT liver generalized increased attenuation on pre-contrast study. Now, these are points to remember. Normal liver is 40 to 70 Hounsfield. Usually it is 45 to 65. Normal liver is 7 to 8 Hounsfield more than the spleen. In hemochromatosis, it can be anywhere between 75 to 130. And if liver density is less than spleen, then it might be fatty liver. So the idea was to show you this increased density. Okay, candidate 5. Rule out hemochromatosis. This is what they want to ask you. They have given you T2 weighted sequence. What do you think? Is there hemochromatosis?
So these are T2 weighted MRI sequences. The liver is hypo-intense compared to the spleen, whereas the pancreas is within normal range and is actually, I'm just having a look at the pancreas. Looks okay, I think. So it is the density of the liver is low, the density. So I would say yes, it is hemochromatosis.
And why do you say it is low? Have you got a criteria? Have you compared it with something, let's say with the muscle or something like that?
Yeah, it's usually with the muscles that you compare with. But actually, looking at back, it looks very similar to the muscles. I can only see the paravertebral muscles in here. But it just, I don't know, to me, it looks slightly hypo-intense,
So can you confirm it on what we'll do? How will you confirm it? Basically, I'm asking you, do you want to do any other sequence which will be more specific?
You can do gradient echo.
So this is not the same case, by the way. This is not the same case. This is another patient. But just on this patient, what is the sequence and what is your conclusion on this case?
So this looks like a T2 star gradient echo, and I would say this is hemochromatosis because the liver is hypointense compared to the muscles I can see.
Okay. this is another patient, and so I have given you sequences. Can you describe the findings and the conclusion? Why, is it hemochromatosis or it's not hemochromatosis?
So T2 star demonstrates hypo-intense liver compared to the surrounding muscles, and the in-phase, out-phase is opposite to what I would see in a fatty liver, suggesting there is iron overload and in keeping with hemochromatosis.
Excellent. Okay, so I take over now. Basically, when hemochromatosis is an exam case. It has come in the exam. They can show you hemochromatosis with cirrhosis, with HCCs, with, pancreas was a good pertinent point which was pointed out by candidate 5. You have to see if pancreas is involved. If the heart is visible, you have to see if there is something going on there also. Having said that, basically what we do is we do a T2-weighted sequence, then we do gradient echo sequence. This is a protocol which is what I call the French protocol. They did a lot of work on this. Here we, in our department, we do various kinds of TRs and TEs. You don't have to remember all of these, but we have increasing gradient, echo TRs and TEs. So it becomes blacker and blacker and blacker. So this is the most sensitive sequence. In this particular example, even on T2, you can see that this is darker as compared to the muscle, but the answer is that gradient echo is much more sensitive. And as was pointed out, that you do in phase and out of phase. And on out of phase, if you see this out of phase, this is brighter as compared to this one, which is what you expect to be seen on a fatty change. Now, I am going to show you a few cases which are in sort of a PACS type of a format. Candidate 5, just to make sure that you are seeing what I am seeing, is there a red slide on your eye in front of you? Case 1? Okay, so this is not a Viva case. I'm just going to teach you on this. I put in 4 or 5 cases just to teach you. Now, this patient is, I have selected a case here to show you biliary leak in a 42-year-old female post-cholecystectomy. So what happened was that this patient, after the cholecystectomy, this was the MRCP, and they had put in a drain, so you can see the drain here. You can see that part of the common hepatic duct level is not visible, but that might be because of edema, etc. So there was a lot of fluid and etc. coming out. So there was a bit of bile there also on lab analysis. They knew that something is there. They put this drain there, and then after a while they thought, or they wanted to make sure that there is no further leakage. So, and for some reasons, they could not do an ERCP, and at that point, nuclear scan was not also available. So we did a hepatobiliary specific contrast MRCP. So on a T2-weighted sequence, this was the anatomy. You can see this drain here. This is the gallbladder fossa. In this gallbladder fossa, there is a bit of fluid. So you don't know this fluid is, active bile or not. This is the main point, right? So then we have got, this is 20-minute delay post, hepatobiliary phase. So this is 20-minute delay, and you can see that on a hepatobiliary phase, this is how a liver looks like in 20-minute. The vessels, etc., are not all that bright, but parenchyma still retains them. On this 20-minute, within that gallbladder fossa, you can see something there. And this is that, you know, that what we call the drain. So you can see something there. You think, oh, something is leaking into this. So what you do is you do a further delay, and this is a 60-minute delay. You know, administratively speaking, it's a big ask. For either the patient has to be on the table, or if it is not on the table, then you can scan somebody else and then bring the patient in. Now this is that drain, and you can see that even this drain looks a bit bright now. So what is happening? And if I am, as we are tracing it backwards, now you can see here that there is contrast pools in the gallbladder fossa. So you have made a black and white diagnosis that there is a biliary leakage. And this is the capability, one of the capabilities of hepatobiliary specific contrast. Right, let's see if I've got, okay, this is a case of, multiple hemangiomas, right upper quadrant pain, gallbladder. So this one on ultrasound was bright, means it looks like a hemangioma, but this is slightly atypical on ultrasound appearance. It is not bright. So on a T2 weighted sequence, look here, this is bright. Another one is here, another one is there. So B600 and bright. So another one maybe here, maybe here. So there are multiple hemangiomas, and on B1200 still they remain bright. Now on arterial phase, now this is that nodular enhancement I was talking about. You see on this lesion, see that there is enhancement, and this is in the periphery, and this is nodular, it is not continuous. And some nodularity here, some nodularity here, some nodularity here. So, and look at this lesion, and again, there is nodular enhancement and discontinuous here. So this is, and look at the signal. This signal is equal to the blood pool. So, and gradually it will fill up. So now it is filling up, and this one is also filling up. And again, look at this signal versus this signal, blood pool. It is the similar signal, and then it has filled up further, and it has filled up signal equal to the blood pool. Now, this is, you know, the late phase, and you are worried, is it washed out? Because the signal is less than the parenchyma. Is it washed out? Then you look carefully and look at the blood pool, and the vessels are also similar. So the key thing is, on all sequences, the signal should be equal to the blood pool. Look here, this one. And again, look at the IVC, look at the portal vein, it is equal. So, you know, there are so many parameters on MR. It's a beautiful tool. You use all of them, and you are very confident of your diagnosis. And 10-minute delay, similar to the blood pool. So this is a case of, what was this? Multifocal HCC. This patient had cirrhosis of liver, 6-month routine ultrasound, but alpha fetoprotein was increasing. On ultrasound, this was the picture. We were not confident of picking up a focal lesion, but on MR, on T2 weighted sequence, there were a few doubtful foci, but the key sequence, of course, you can see cirrhosis there. The key sequence on diffusion, there was a bit of restricted diffusion. For example, here on arterial, look here, 1, 2, 3, 4, 5. I think there were 8 odd lesions, if I'm not wrong. And so they enhanced. So this is the key finding in HCCs. That, and then there should be a washout. You see, it becomes black as compared to the parenchyma. and all of them, they become black. So this is the criteria to diagnose HCC. Look, this one is also becoming black. So, and they are beautifully seen here as, so this phase is 20 minutes. And this tells you the second, you see, this is a 20-minute delay, and because HCCs, there is no normal hepatocyte, it will become black. So your confidence level really increases. So this case is a case of, the what we call HCC, which is causing tumor thrombus. If you see this CT scan, this is an interesting CT scan, where you don't see the portal vein, you see this tumor which is going into the vein. You can, stretch your imagination that this is the portal vein. There is collaterals around it, cavernous transformation type of a thing. Even here, the tumor is going in. But we have got a venous phase here, so we did not have an arterial phase. On arterial phase, there is a bit of enhancement here. But the key thing here, which I want to show you on venous phase, this is it. Again, you are not sure if there is tumor or whatever. And look at this, T2 is very good. It shows something is happening. But look at the diffusion. Diffusion was brilliant in this case. You see how beautifully it highlights. And this is an exam case, and it has come in the exam many a times. Tumor thrombus. On ADC, it shows restricted diffusion. So this is a case of pyogenic cholangitis. And this case, on a CT scan, there was, previous surgery, there was a stent, etc. The patient developed fever, etc. There were things happening on this CT scan, but on diffusion, now this time the diffusion has picked up abscesses. So look at this diffusion, and you can see that within the intrahepatic ducts, because the ducts are dilated, then with that there are what we call micro abscesses. So everything is showing restricted diffusion. So another use of suppurative cholangitis, and you can see this on MR much more beautifully than the CT scan. Okay, so I think what we'll do is that we will take a 5-minute break, and after the break, candidate 5, thank you very much. It will be candidate 6 after the break.